What I'd like to talk about is thinking about some of the ways in which a global registry can be used. The data from it can be extracted and used to ask and answer a whole series of questions that can help us understand how to deliver better clinical care to patients with hemophilia and bleeding disorders. And so I think we're all aware of the burden of hemophilia on individuals. The fact that it's expensive, the fact that if patients are on prophylaxis, it's difficult to adhere to those regimens, and that we have complications associated with treatment. I want to give one example of where treatment is difficult to carry out and complications can arise. This is a study that came from the Centers for Disease Control in the United States and was published over the last couple of years. And surprisingly, it looked at patients on prophylaxis and found that in a very large cohort of about 5,000 patients, 33% on prophylaxis had about one bleed a month. 25% had target joints. Disability was high, and school and work absences were high as well. So I think this was a wake-up call that just because we assume that we have a prophylaxis regimen, we can't necessarily assume it's being used effectively in all cases, in all places, and that there's a lot more work to do. So it's an example of what you may not be able to see if you look at an individual treatment center or a small group of patients, but you can see if you look at the entire country, which is what this did. And so it points out the power of looking at a lot of patients, a lot of data, and uncovering events such as this that can then allow one to develop strategies to improve care and prophylaxis in individuals with bleeding disorders. We have a number of complications associated with hemophilia. They include inhibitors, as we know, which occur in a high minority of individuals, but there's also rare events. And so we're dealing with a rare disease anyway, factor VIII or factor IX deficiency, and then we have rare events on top of that. Two examples I've got here are pseudotumors and intracranial hemorrhages. We don't have very good data at all on the natural history of those two events, and we're not going to get those data from one country or two or three treatment centers. We're only going to be able to get that if we can pool data from large numbers of treatment centers. By getting that natural history and understanding the morbidity and mortality that's associated with rare events such as this, we can then begin to develop better strategies to either prevent them or treat them more effectively. I'm going to give a series of other examples. We have gaps in the data when we look at gender and racial disparities. We know we have a higher inhibitor rate in African Americans, but we really don't know why. We don't have a good handle on other ethnicities either. For instance, Hispanics, Asians, Caucasians. What are the differences? And if we did understand in large cohorts of patients what those differences were, that would be important for understanding more about the risk factors for inhibitor generation. Bleeding disorders in women, I think, is greatly under-recognized. We call women who have the hemophilia gene carriers, but in reality, many of them have mild and in some cases moderate hemophilia and have significant complications from bleeding. It's another area where we don't have a good handle on the natural history, but yet obtaining lots of information from large numbers of patients can really help us to understand the natural history of the disease in women. And so when we think about pooling data together in large registries, we also need to make sure that we use common definitions and are able to collect the data in a way that it can be shared with other databases to generate the large data required to make these kinds of discoveries and conclusions. So the definitions are important. Many definitions have been established, in some cases by the ISTH, the Subcommittee for Standards and Criteria. And in other cases, we don't have full harmonization of definitions on various parameters in hemophilia, such as the definition of a bleeding episode, and more work needs to be done. But this is really important to allow us to compare databases. I want to talk for a couple of moments about prophylaxis regimens, including low-dose prophylaxis. This has been done successfully now in a number of countries, some on their own, some in conjunction with the Humanitarian Aid Program, the expanded program with the World Federation of Hemophilia. And we've had some very good reports come out of Tunisia, Turkey, China, as well as India that have demonstrated the benefits of low-dose prophylaxis. But what we need is much more information that can be pulled together to truly understand the natural history of how patients do with low-dose prophylaxis, where it can be used effectively, where it may not be able to be used effectively, such as in individuals who have a lot of target joints, so that we can come up with more standard criteria and then be able to elevate the treatment in patients around the world. We seem to be losing our screens. There we go. And the same kind of rationale applies to surgery studies. So how can we effectively do surgery with a minimum but an effective amount of clotting factor concentrate? Can we share protocols? Can we get data from a number of different types of surgeries and begin to establish the minimum requirements for being able to do different types of surgeries in individuals with hemophilia? So none of this can really be done taking the data from a single treatment center or even a single country, but by pooling large amounts of data, we can do much more to set the standard for data collection for hemophilia. We can compare country data between two different countries. We can compare data between individuals that are around the world. And most importantly, we can look at rare events, the kinds of events that may only occur in one or two patients in a treatment center and can't really effectively describe the natural history of that event, such as pseudotumors or intracranial hemorrhages. But by looking throughout the world, we can do much more to be able to identify those risk factors and then begin to develop the standards for treatment. So there's additional questions. There are thousands of questions that can be asked and answered if we have the data available. And they're important questions for defining the state of the art for treatment, the standards of care for the treatment of individuals with bleeding disorders. Here's another example. What about home treatment? How does that affect the development of target joints, hospitalization, the risks of intracranial hemorrhage? And the sequelae from intracranial hemorrhages, if we've got the ability to either treat at home or if patients need to go into a hospital. So these are the kinds of questions that I think we can begin asking and answering once we have large numbers of data, patient data. If we put patients on low-dose prophylaxis, could we actually save factor compared to treating them on demand? I think that there's evidence from some smaller studies that that is possible, but it's only if we can develop this in a much more broader capacity can we really answer the question and then use that information to elevate treatment standards. And what about the intracranial hemorrhages? What's the natural history? What's the risk factors? We know that they can occur at birth. We also know they can occur throughout life. We know if you've had one, you're at risk for more. And what can we do to increase the standards for the treatment and management of intracranial hemorrhage, and most importantly, prevention of intracranial hemorrhages? So to finish up, I'll start with what's at the bottom, and it's something I have said before with regard to the World Bleeding Disorders Registry. If we don't know where we are today, how do we know where we're going with regard to treatment? So the key is to get standardized data collection from large numbers of centers, to use those data to generate evidence that can then allow us to ask the kinds of research questions that I have posed here in the earlier slides. By asking and answering those research questions, we can then define the conclusions to increase standards of care for individuals with hemophilia. By increasing those standards of care, then we elevate it throughout the world. All of this is used also for advocacy. So we can't do advocacy unless we've generated the data with which to represent to governments, to payers, what the effectiveness of treatment is. So it comes down to what's on the right-hand side of this slide. If we don't have a registry, we're not going to generate any data. If we don't generate any data, we can't do advocacy. If we don't have advocacy, there's no opportunity for improved treatment. And if there's no opportunity for improved treatment, we're stuck with the status quo. So taken together, it, I think, demonstrates the importance of developing these larger databases to allow for the sharing of data, to work with other databases that already exist, to be able to pool the data and ask and answer these kinds of research questions. With that, thank you, and we'll continue.